Okay, can everyone see my screen?
Yep.
Okay, sounds good. So we'll begin with the session about critical appraisal of scientific literature. So why is critical appraisal necessary? This is something that I touched on earlier when we were having a chat. Um, it's basically to practice evidence-based medicine. S- Guidelines and management of patients depends on evidence. The management that we put in place when we're working clinically, that should all be evidence-based. Practicing evidence-based medicine helps you to know that what you're doing for your patients is actually increasing benefits and reducing harm with a clear rationale as to why you're doing it. It's not guesswork. There are lots of journals out there, we know this. Not everyone has a rigorous process of reviewing literature submitted to them to ensure that only robust evidence is produced, unfortunately. And now, with residency and fellowship positions based heavily on research experience, the aim has now somewhat shifted to quantity rather than quality of research. It used to be the case that systematic reviews and meta-analysis were the highest form of scientific evidence. But with more people now doing a variety of courses on conducting systematic review and meta-analyses, not all of them adhere to strict standards or are of the highest quality. So we need to be able to spot these, especially since not all reviewers know how to properly appraise this type of research before accepting them for publication. Even if you're reading systematic reviews or meta-analyses published in a good quality journal, excuse me, the evidence may not be applicable to you or your practice. And I've seen some meta-analyses in very high impact factor journals that have had problems or have had, some small things that were wrong with them. So it's important to make sure that you do everything you can when you're producing research or when you're reading research to ensure that you're doing what's best for you and your patients. So the objectives for this session to review current understanding uh, and have an overview of critical appraisals. And then we're going to talk a little bit more specifically about appraising randomized control trials using a structured framework. And then more importantly, about appraising systematic review and meta-analyses of randomized control trials. And then we will just talk about some differences in terms of observational studies. So in terms of current understanding, what do you guys look for when evaluating a paper, whether it's a systematic review or a meta-analysis, or an RCT, like a standalone RCT? What do you guys look for? It doesn't have to be in order. I know some of you have attended previous sessions, so um, can you think of anything that you look for in particular when you're appraising a paper?
I look at the the search methods when we're talking about systematic reviews,
Mm-hmm.
like how in depth the search was. Is it likely that they got all the research that's out there on this topic?
Yep, correct. Anyone else? No? Okay. We will go through it and hopefully you'll know by the end of end of the session, what you are looking for. So just as an overview, so we're going to use some checklists that I found online through a course that I did, and I'll share some details afterwards. Um, the general structure of these checklists is they've got four sections. So the first section looks at, is the study design valid, whether it's for an RCT or a systematic review and meta-analysis. Section B looks at, is the study methodologically sound? Section C looks at, what are the results and are they trustworthy? And then the last section looks at, are the results relevant locally? So when you put all of this together, you should have a very clear idea of, when you're looking at a paper, if that paper is good quality paper, was the research good quality, and are the results relevant to where you work? So just touching on critical appraisal of randomized control trials as a standalone, this is like without the meta-analysis systematic review part. If you're looking at a standalone RCT. So we start off with, in section A, is the study design valid for an RCT? And here you look at the PICO question, which is you look at the population that was studied, the intervention that was given, the comparator that was chosen, and the outcomes that were measured. So, did they have a clearly formulated research question covering all of these different aspects? Was the assignment of the participants to the intervention, was that randomized? So here you're looking at, how was the randomization carried out? Was the method appropriate? So did they use a computer system, or did they just, assign, uh, kind of, they alternated which group participants went into, those kind of things. You're looking at the method, how it was randomized, and was it appropriate? Was randomization sufficient to eliminate systematic bias? And was the allocation sequence concealed from investigators and participants? So was this a single blind trial? Was this a double blind trial? All of that has an effect on the overall bias. Were all participants who entered the study accounted for at its conclusion? So, was anyone lost to follow up, and exclusions after randomization accounted for? Were participants analyzed in the study groups to which they were randomized? So, intention to treat analysis. And was the study stopped early? And if so, what was the reason? So, at all these different points, you can have bias introduced to your trial. And that's why they look very strictly at how each method of randomization was carried out. Section B. So firstly, here we're looking at, was the methodology sound? So to begin with, were the participants blind to the level, to the intervention they were given, and what was the level of the blinding? Was it just the participants, the investigators, and the people analyzing the data? Were they all blind, or was it only some of them? What were the baseline characteristics of the participants in each group? So we're looking at their demographics, their age, sex, socioeconomic group. And a lot of papers actually, they have a table to compare if there were any significant differences between the demographics of the two groups. And there you want to know that there aren't any significant differences. And were there any differences between the study groups that could affect the overall outcome? Again, you don't want there to be any big differences there. And then you want to look at, apart from the experimental intervention, was each study group, did they receive the same level of care? So did they have, so if they had any intervention, did the control group receive a similar form, like if it was a tablet, for example, did they receive a placebo tablet? Or, if the intervention group had, weekly check-ins, did the control group also have weekly check-ins, even though they weren't looking for any, they weren't expecting any differences, but they need to be treated exactly the same apart from the one intervention that's different. And were the follow-up intervals, like I said, the same for each group? Section C looks at what are the actual results. Were the effects of the intervention reported comprehensively? So the overall effect whether that's a risk ratio, an odds ratio, however they're measuring the difference between the different, if there's a mean difference or a standardized mean difference, how are they measuring a difference between the two groups? And has it been done comprehensively? So, for example, was a power calculation undertaken before the study started? So, what would be the minimum power of the study, and what uh, you can do calculations beforehand to ensure what would be a significant result. And like I said, it's better to be done beforehand rather than after you have the results. What were the outcomes that were measured, and were they clearly specified? How were the results expressed? So for binary outcomes, were they relative? Did they have relative and absolute effects? So you can have a relative ratio and like a relative risk ratio, or you can also have an absolute uh, difference. Were the results reported for each outcome in each study group at each follow-up? So you're not just having the overall results, you're having, the results at each time that they were seen. So that's more comprehensive. Was there any missing or incomplete data? Was there a differential dropout between the study groups that could affect the results? So if more people dropped out in the intervention group and fewer people dropped out in the control group, then the overall results will be affected. So at that point, you use intention to treat analysis, where you analyze the data according to who was randomized where, or do you do it per protocol, which is done afterwards and doesn't take into account the fact that X amount of people dropped out? Were potential sources of bias identified? So the people doing the research, did they identify where they could have introduced bias themselves? And which statistical tests were used, and were p-values reported? Okay. Lastly, in section D, we look at, will the results help locally? So actually, I missed the last part in this. Do the benefits of the experimental intervention outweigh the harms? So we have to also look at what harms or unintended effects were reported for each of the study groups, and was a cost effectiveness analysis undertaken? So that also has to be taken into account before you implement an intervention, because it will come with changes, it will come with resource requirements, usually, it will come with additional training, for example. So that all needs to be taken into account. And if the group doing the trial has reported on this, it means that they've taken all of these things into consideration, and their overall trial and study is more comprehensive. And then, yeah, lastly, we'll look at if the results help locally. So, can the results be applied to your local population? And this is very subjective. This is very specific to where you work. And this is when you have a look at trials and you think, should I change my practice? Is this going to help my patients? This is where you have to look at the relevance to your own population. So, are the study participants similar to your patient population? If there are differences, would these affect the outcomes? Are the outcomes important to your population? Are there any outcomes that you would have been interested in that are not included in the study? And do the limitations of the study affect your decision? And lastly, would the experimental intervention provide greater value to the people in your care than any of the existing interventions? So, if you already have a good system that's helping your patients and has a good outcome overall, and you see a new study that says there's marginal better improvements, using this new medication than the one that you're currently using, but actually you have to treat like 200 people for one person to have an additional effect. But along with that, you have to have additional training, you have to have additional resources. So is that clinically relevant to your patients? And does it have that much more benefit than the existing treatment? If it doesn't, then you're good where you are. So that's a very quick overview on appraising randomized control trials. Any questions so far? Have I lost anyone?
I wanted to ask one question.
Yeah.
What could be the limitations of the study?
So limitations of the study can cover lots of different things. So, for example, a small sample size in an RCT, if they used 5 people against 5 other people, they can talk about the limitations and state that actually we had a very small sample size. Another limitation can be, sorry, excuse me. Another limitation can be where they sourced their population from. If it's only from one hospital in one city, that's very like remote, for example, will does that population, and it might be a more elderly population, for example, does that population still hold true for someone who's living in New York, London, and they have a very different demographic, and they haven't, the study hasn't looked at national, it hasn't sourced their sample from a national population, it's only from a very specific cohort, like a geographical cohort. Another thing they could talk about limitations is if they've had a huge amount of dropout from if they've had huge dropouts from one group rather than the other, that's a limitation. If, for example, they've got uh, the, I was thinking, sorry, someone came into the rooms. I admit to them, I completely forgot what I was saying. But there's lots of different areas of. Oh, yes, that's what I was saying. If they have only been single blinded, so only the participants didn't know their allocation, but actually the people, the investigators or the people giving the drugs knew which drug they were giving to which participant, and they weren't double blind or even triple blind, for example.
Yeah.
So
So,
it's very dependent on studies, but if you as a reader can find, where bias may be introduced or the precision or the validity of the study could be affected, are the investigators in the study, are they able to also find that and address it and write that in their limitations? So at least you know that they are aware of the problem.
yeah. So the double-blinded or a triple-blinded study is always better than a single-blinded study.
Sorry, say that again?
I said a double-blinded study or a triple-blinded study is always better than a single-blinded study, right?
That's always better because it has less it has less
Less
risk of
chances of bias.
bias. That's correct. Yeah. Because the participants can be blind to which group they're in. But if the person giving the intervention or the medication, for example, knows which group they're giving the medication to, they might change their behavior without knowing. So, if they're seeing a patient in clinic and they know they're getting the experimental drug, they might ask them more questions about how they're doing. They might ask them more questions about side effects from the medication. They might, just take more interest in their overall well-being. And some patients, the extra care that they get because of that, that might help their outcomes. They might help them feel less depressed with their condition. It might help them feel more heard, in which case they might change their behaviors and have that might have an impact on their health. So there's lots of ways that you can subconsciously kind of introduce bias in a study. But if fewer people know who is getting the intervention and who is getting the treatment, including the analysts afterwards. So that's where the triple blind comes in. So the people who are doing the statistical analysis, if they don't know who was in which group, they've just been given numbers to kind of run through the mathematical system, then they are less likely to subconsciously affect those numbers. Does that make sense?
Yeah, yeah. Thank you.
Right. Any other questions? Otherwise, I'll move on.
No, I don't.
Okay, perfect. So, right. So now we're looking at critical appraisal of systematic reviews and meta-analysis of RCTs. So this is important because most of the time, I think I personally am reluctant to just take information from a standalone RCT to change my practice. It might be a great RCT, but systematic reviews and meta-analyses are the highest form of like scientific evidence. So usually I will look at, kind of the pooled data in a meta-analysis to see if one intervention is in fact better than another. But like I said, the quality of systematic reviews and meta-analyses being produced these days has definitely gone down, um, and not all of them are robust. So you need to be able to know how to identify the ones that have, kind of taken shortcuts maybe, or haven't done their analysis in the best way. And this is the kind of checklist we usually focus on in MedLit Dissect, because we're usually looking at meta-analysis. So this is the helpful checklist to kind of focus on. So this begins with section A, again, very similar to what we did before. Did the systematic review address a clearly formulated question? And again, you've got your PCODS criteria here. You're looking at your population, your intervention, a comparator, the outcome measures, the study time or the follow-up intervals, and the setting. Now, here you want to go through that systematic review and meta-analysis and make sure they've identified all of these things very, very clearly. Because if you are looking at, 10 different studies that you're analyzing in your meta-analysis, and all of them have a slightly different population or a slightly different comparator or looking at slightly different outcomes, unless you know very, very clearly what it is that you're looking at, black and white, no gray areas, then you are going to have a huge amount of variation and no real results in your, or no real valid results in your meta-analysis. So this is the first thing we look at. Then we go on to the second part. So did the researchers search for appropriate study designs to answer the research question? So here we want to make sure that if the research is concerned with the efficacy of an intervention, for example, ideally they should be looking at randomized control trials. The most common type of randomized control trial is a parallel randomized control trial, but there's lots of other kinds. You just want to make sure that depending on the research question, they've got the appropriate one. Right. And then we look at section B. Is the study design valid for a systematic review? So were all the relevant, and systematic review is very specific. It's not just a quick, PubMed search to see what are the top, 20 articles that you can be bothered to look through, and you're, seeing if you can include any of those, if any of those meet your inclusion criteria or not. It's a very like methodological, rigid way of trying to identify everything out there that could possibly be relevant to the research question. So you're not trying to be biased with, what's the most heavily cited research. You're looking at everything that's currently available on the topic that you're researching. So here, you're also considering, was the search strategy comprehensive and clearly reported? So a lot of these systematic reviews will provide a table with their search strategy. You want to look through it from what you know about searching for literature, and you want to see if, there's a comprehensive, thought out way of doing it, or, have they just used, the the minimum amount of words relevant to their study when searching for papers. A good thing here to include if you are doing your own research and you have access to a hospital librarian or a university librarian, they usually have training in search strategies, and they're probably the best people to ask in terms of coming up with a comprehensive search strategy. So if papers out there say that, we employed the help of a hospital librarian to come up with this comprehensive search strategy, that's a very good sign. Now, there was a very good paper published in a good journal that we looked at in MedLit Dissect a few weeks ago, and it was, in a high quality journal. And their search strategy was just the title um, of the systematic review, kind of broken up in chunks. So they had like one word for the population, they had one word for the intervention, they had one word for the comparator, they had one word for the outcome. And someone then repeated their systematic review, someone separately, when they read their paper, they repeated the systematic review with a more comprehensive search strategy, and they identified over 1,000 extra articles that, met the search terms. Obviously, then you have to go through it and see which one's actually relevant, but it identified an extra 1,000 or more uh, articles that could have been relevant to this paper. So it's very important to come up with a comprehensive search strategy. And then did they search one or more of the major bibliographic databases? So that includes PubMed, Embase, Scopus, Web of Science, the Cochrane Library, Central, which I think is the Cochrane one for trials. There's lots of different, and then you can have like subject specific ones. So there's a psychiatry or psychology specific one. So have a look at which databases and have a real think about which databases to use. You should use all of the main, like the big ones if you have access to them, and also any specific ones that might be relevant to to your research. And then were non-English studies also looked at, or were the studies limited to English only? Now, most of the Western research papers that you read will probably limit their search to English only, because it's hard enough kind of speaking another language. It's even more difficult to read scientific literature in another language. So unless there's a native speaker in the group who can translate, it's really difficult. So a lot of them will exclude any non-English articles, but again, that there's very, very good quality evidence that's coming out from the rest of the world as well. So that has to be something that you address in your limitations if that's what you've done. Did they conduct hand searching of reference lists from primary research studies included in the systematic review? So if they've got 10 studies that they're looking at for the meta-analysis, have they looked through the references in that to identify if there's any other papers that might be relevant to them? Did they look at unpublished studies? So this is called gray literature. So unpublished studies can be, things like PhD thesis. It can be, good quality research that actually doesn't have any significant findings. But because of things like publication bias, where studies with positive findings or significant findings are more likely to be published than ones with negative findings. So if you've looked at an intervention and a comparator and said there's absolutely no difference between using these two, it might be less likely to be published, but it's still good quality research to know that actually in under strict environment and under a strictly controlled environment, these two things, there was no difference in their outcomes. That's important to know, but it might not be published. So it's good to look at unpublished studies if you have access to them. And then you can also consult experts in the field about potential primary research studies or ongoing trials. So if you're doing a study, on myeloma, for example, it's useful to go and approach someone who works in the field and is an expert in the field of myeloma, and they might identify extra studies or extra trials that might be ongoing that they know of, or ones that have recently been published that you might not have identified in your search, and that could be helpful for you in your analysis. And then the next part goes on to talking about um, screening of the primary research studies from the search. So, did the researchers define appropriate eligibility or inclusion and exclusion criteria? I cannot stress the importance of this in a meta-analysis and a systematic review because you will get such a huge variety of information from different studies because everyone looks at things a little from a different lens. So if you aren't clear on your inclusion and exclusion criteria, you can really muddy the waters when it comes to your overall analysis. Did the researchers design and implement a robust process to screen the primary research studies? For example, two researchers working independently with a third researcher to resolve any disagreements. So there's lots of programs where you can import all of your identified studies and then go through, the title and abstract screening and then the full text screening. The best way to do it is to have at least two people going through and making their own independent decision whether to include a study or to exclude it. And they will have some conflicts. They're two independent people making their own decisions. They might, one might have said yes to including a study and the other one might have said no. That's when a third independent person comes in and looks at the conflicts and then decides whether those conflicted studies should be included or not. And it's the best way to try and reduce the bias. Was screening based on title and abstract? And did the researchers adhere to the eligibility criteria? So there was a study that I looked at where they said they want to include studies in the meta-analysis that the primary study should have at least 70%, of X population. I think they were looking at physicians or something. Um, but then there was a little addendum in the results section saying, oh, we found a study that included 65% of, 65% of their participants were physicians. And yeah, we had initially said we wanted at least 70% for our inclusion criteria, but we thought this had good results and it's only 5% off. So we decided to include it anyway. That's really bad kind of practice. And, that does bias your results that after you've come up with your inclusion exclusion criteria, you've looked at the research that's out there and then amended it to suit what you think should and shouldn't be included. So definitely have a look at whether they have actually adhered to their criteria or not, because it doesn't always happen. It seems so simple, but it doesn't always happen. Then we look at selecting the primary studies that they've included. So did they have a robust process to select the primary studies that were included? For example, two researchers, again, working independently. So this is, I think, once they've done the full text screening. Was the decision to include or exclude primary research studies based on full text analysis? Did the researchers, again, here adhere to the eligibility criteria? And this is really important. Did they calculate the kappa statistic of inter-rater reliability? Now, a Cohen's kappa score is calculated based on how similar the decisions of the two researchers were. So if from 100 studies, if the one researcher decided to include 25 and the other researcher decided to include 75, then the difference in their ratings is quite large. Whereas, if out of the 100 studies, the two independent researchers, when they were screening, they agreed on 90% of the studies, whether that was including or excluding. They made the same decision about on 90% of the studies, but only in 10% of the studies, they had a difference in opinion. That's actually a pretty high Cohen's kappa score. So it helps to know that, if there's a very low agreement between the two researchers, then essentially you know that the third person is making most of the decisions about which studies to include or exclude based on their kind of conflict resolution between the two researchers. But if the two independent researchers initially had very high levels of agreement, that means, they are looking at the same eligibility criteria, inclusion, exclusion criteria, and, making the same decisions about those papers. So it's a very good statistic. Not everyone includes it, but when you know about it, it's very good to report on that. And then lastly, in this section B, we're looking at summarizing of the studies. So did they include a Prisma chart, a Prisma diagram showing, how many studies were initially identified, were duplicates removed, and how many were screened out during title and abstract screening, how many were screened out during full text screening, and if they were excluded, have they provided reasons for exclusion? And the ones that were included in the meta-analysis, have they uh, kind of given any details about that? And then we talk about once they've identified which studies they want to include. So they might have screened 1,000 studies and decided to include 5 different studies. Did the researchers assess the validity or methodological rigor of each of the primary studies? So this means, did they use a validated tool to assess, if there was any bias or what the methodology? So earlier we looked at how to assess the validity and the methodology of a randomized control trial. So you do something similar to that, but there are validated tools out there like the Cochrane risk of bias tool, where you go through each of the studies you're including in your meta-analysis and you answer questions in that Cochrane risk of bias tool. And it'll tell you whether there was a low risk of bias, whether there was a moderate risk of bias, or a high risk of bias in the study that you're looking at. It doesn't mean you can't include that study. It just means that you have to keep that in mind for your analysis. Because if a study with a high risk of bias is having a huge impact on the overall result of your meta-analysis, then you want to see, okay, if we remove this one study that's got a big risk of bias, but is highly influencing the results of our meta-analysis, will the results of the meta-analysis still be significant without this one problematic study, for example? And then the tool that they use to assess the methodology of these studies, was it a validated tool? So you can use the Cochrane risk of bias tool, which is specifically made for assessing randomized control trials, or you can use, I think it's called the Newcastle Ottawa um, scoring system for observational studies. There's also a McMaster EPHPP tool for quantitative studies as well, instead of the Cochrane risk of bias. But depending on the study design, there are different tools out there that are gold standard for assessing their risk of bias. So make sure you're using the correct one for the correct type of studies. And did the researchers present the findings from their quality assessment and interpret them accurately? So if they have done a Cochrane risk of bias assessment, did they include that? It gives you a little traffic light matrix, and you can include that in your overall paper, or you can include that in the supplementary material with the overall results. But it's really important to actually be very clear about and very transparent about your risk of bias assessment and the results from it, so that someone else, when they're repeating and they're trying to reproduce your research, they can see what your assessment of each study was, and if there was a problem, if you misunderstood something, for example. Then we look at, did the researchers extract and present information from the individual primary studies appropriately and transparently? So in the extraction of the data, we're looking at did the researchers design and implement a robust process for extraction of the data from individual studies? And did they follow any guidance on data extraction? Or did they use a standardized form or software program to record the data? So apparently there are programs out there that can do your data extraction for you. I've never used one. I've always kind of done it myself and checked it over, you know, 100 times before using it for my meta-analysis, got other people to check it over, made changes, etc. So the data extraction part of a meta-analysis is perhaps the most important part, because if you put garbage data in that extraction table, you'll get garbage results out. If you put the wrong data in there, you'll get the wrong results out. So it's really important that, your data extraction is robust, and different studies will report on different outcomes. And even if they're reporting on the same outcomes, they might measure things differently. So some studies might look at, the difference between two groups. Some studies might look at the relative difference between two groups. So some studies might look at hazard ratios instead of relative risk. So it's important that, if you are standardizing what you're looking at, and standardizing the results that you're comparing. Otherwise, they're not comparable. And then we talk about presentation of the data. So did the researchers present the key characteristics of the individual primary studies in a table, for example? So all the data that they've extracted, have they provided it in the supplementary material or in the actual paper to say, for each individual studies, these are all the outcomes you measured and this is what the results were? Did they present the results of the individual primary studies in a forest plot? Or a combination of forest plots. So once you have run your meta-analysis, did you provide forest plots to show the overall combination of results? And did they have the effect sizes and the confidence interval and p-values of the overall results stated? So if at this point you have any problems with the methodology, then you can either, if it's just a few things here and there, then you can keep it in mind while moving on. But if you have lots of no's in these columns to be like, this wasn't done properly, this wasn't done properly, then you can even just stop your analysis here. Because if the methodology isn't good, then the results aren't going to be good. You don't have to go and analyze the results afterwards to complete the checklist if you found that the methodology was hugely problematic. And then in section C, are the results trustworthy? So if you've answered yes and with a few can't tells in the previous section, then you know that you're looking at a study that you're thinking, okay, it's not perfect. There's a few things to keep in mind that are limitations, but overall they've done a good job, and overall, their methodology is pretty good. Then you can move on to see if the results are as good or if the results are garbage. So here we're looking at, did the researchers analyze the pooled results of the individual primary studies appropriately? So this is a long section because there's lots of things in the results to look at. So here you're looking at A, was a power calculation and sample size estimation done during the design and planning stages of the systematic review. So this is even before you have started to undertake the systematic review and meta-analysis. Did they do a power calculation to know what would be significant and what would not be significant, and what kind of sample size they're looking at, or they would need to declare significant results? It's not an easy thing to do. So not everyone does it, but if it has been done, it's really good, and it would make me more confident in their overall methodology. Did the number of participants whose outcomes were entered into the analysis meet the power calculation? As in, was the meta-analysis sufficiently powered? So if they have done a power calculation, did their results meet the power calculation? Did they have enough studies? Did they have enough, participants in the pooled analysis to meet that minimum power calculation? Did the researchers use an appropriate effect measure? So, whether that's a relative effect measure or an absolute, kind of mean difference, standardized mean difference, was it appropriate for what they were looking at? Did they provide confidence interval ranges? Did they provide p-values? Did they also provide heterogeneity among the primary studies. For example, using the I-squared statistic. Now, in a meta-analysis, this is perhaps, one of the most important things that you can report on. And I don't know how you can do a meta-analysis without reporting on the heterogeneity. So the I-squared statistic will tell you, so you'll have the overall result with the p-value, whether, the overall meta-analysis shows that there's a significant difference between the intervention and the comparator. And you'll have an I-squared statistic with its own kind of p-value. Now, this will tell you that, was there a huge variation between the studies in terms of the overall results? And if you're, getting close to the 80, 90%, 70, 80, 90% heterogeneity, then you know that you have to be very careful, even if you have a significant overall result for the meta-analysis, you have to be very careful interpreting those results because actually there is huge disagreements between the different studies in regards to that overall result. So if you've got low heterogeneity, kind of below 30%, and you have a significant overall result, that means that there's a high level of agreement between the different studies that that result is significant, so you can trust it more. Did the meta-analysis that was conducted, did they use a random effects model or did they use a fixed effects model? Now, I don't know how many of you know the difference between a random effects model and a fixed effects model, but most research that we carry out in healthcare is, uses the random effects model just because there is so much innate variation between humans, right? And our behavior and our response to different medications and different interventions. So usually most healthcare research uses a random effects model for their meta-analysis. If they don't, and if they use a fixed effect model, that the fixed effect model assumes that, there's very little variation in the study participants overall, which doesn't seem to be the case in healthcare. But if they have used that, they should provide a good reason as to why they've used a fixed effects model. And this is all to do with like the in-depth formula that kind of underlies meta-analysis. It's not for, day to day. For us, it's not really kind of relevant to know the ins and outs of exactly how a random effects model is calculated or how a fixed effects model is calculated. It's just when you're whether using the R Studio, whether using RevMan, before you do your analysis, you have to just tell the program which model you want it to use, and then it'll churn out some numbers. So once they've done that, did they do a sensitivity analysis or a subgroup analysis or meta-regression? So, here you're looking at if you have huge variations and a huge amount of heterogeneity, you do kind of mini meta-analyses by, different grouping it with the different subgroups. So one of the subgroups could be a risk of bias analysis. So you look at, if you rerun the meta-analysis, splitting up into the different groups of the risk of bias, whether that's low risk of bias, medium, or high. Do you get significant results in the from the papers that were high risk of bias, but you get non-significant results in the papers that were low risk of bias, and that can show you why you've got so much heterogeneity in your over meta-analysis. You can also look at, an influence analysis or a sensitivity analysis, where, you do the meta-analysis, you ask the program to redo the meta-analysis, removing one study at a time to see which study was having the most influence on the overall results. And if it was a disproportionate amount of influence, depending on how many study participants that study had, and if it was a good quality study. And did they look at the small study effect and assess for any potential for publication bias using a funnel plot or using an Eggers test? So for an Eggers test, I think you need to have minimum 10 studies in your meta-analysis. Otherwise, it doesn't churn out any numbers. But you can do a funnel plot to see if there's, symmetry in the published results. Because like I said before, publication bias can mean that studies with positive results or significant results are more likely to be published. And studies that have maybe like a bigger sample size might be more likely to be published. So when you do your funnel plot, it'll plot where your different studies lie, and you can see if there's symmetry or asymmetry in the studies that you have analyzed. And if there is, then you need to mention this in your limitation that actually there might be possible, small study effect or potential publication bias, and that influences your overall meta-analysis. And then if a subgroup analysis has been done, then you can look at the results of the subgroup analysis. Were the subgroups pre-specified in the study protocol? Because if you do your meta-analysis and you find that actually there is a huge amount of variation, and then you look at, what's causing this variation, and then you do your subgroup analysis, it's not as good practice as specifying your subgroups beforehand, because that reduces your bias. You're not looking at the results and then creating subgroups. Subgroup analysis is very useful, but it's used more to generate hypotheses rather than answer questions. So when you do a subgroup analysis, you're saying, we think possibly it could be that, the subgroup of higher socioeconomic status is affecting the results or has an effect on the overall results compared to the low socioeconomic group. Or, you can have a subgroup by country. So you can have 10 studies from 5 different countries, but when you split them up into different subgroups, the results from one country might be significant, results from another country might not be significant. So this is just to generate further hypotheses, and then you can do further meta-analysis later on that are properly planned, that are looking at these subgroups to see if there's a big variation between the results from, China compared to the results from the UK, for example. Were the subgroups clearly predefined with a rationale for selection? And were they analyzed afterwards? And whether any subgroup effects were statistically significant. So if you have a high risk of bias subgroup and their results are statistically significant, but the low risk of bias subgroup has non-statistically significant results, then you can mention that and say that actually, our overall meta-analysis was being biased by the studies with a high risk of bias. If they did a meta-regression, you can have look at the meta-regression. Again, it sees how closely, this is more for continuous data, but how closely the different studies lie to the meta-regression line, and, if there's a huge amount of variation there. And then you move on to the limitations. So again, this is a large part of the analysis, because you want to make sure that if they have any limitations, they've addressed it, and that they know the limitations of their own study and how they can reduce that next time, for example. So did the researchers report any limitations of the systematic review? And if so, do the limitations discuss all of the issues that you identified during your critical appraisal? So, for example, was it sufficiently powered? If it wasn't sufficiently powered, did they address that? Did they consider the appropriateness of the effect measure that they used? If they used the wrong effect measure, did they comment on that and, address that? Did they, for example, if the forest plots crossed the line of no effect, so whether that's 0 for mean difference or 1 for a relative risk, if it crossed that line, did they address that and say that actually, the confidence interval included the line of no effect, so it is possible that there is actually no difference between the two groups? If the results were statistically significant, did the researchers discuss whether the results would be important or meaningful for the outcomes? Are they clinically relevant, even if they were statistically significant? Did they consider whether relevant primary research studies could have been missed? So if they didn't have a very robust search strategy, did they comment on that in their limitations and say, actually, we realized that our search strategy wasn't the best. We think we could have missed relevant studies, or we only included English studies, which is the limitation for our overall research. Perhaps next time we could look at including non-English studies or unpublished studies to make sure that we're including everything that's available to us on this topic. Did the researchers mention any systematic bias identified during the risk of bias or quality assessment of the individual studies and how that could have influenced the outcomes? So if, like I keep saying, if the high risk of bias studies are having a huge impact in the overall results, have they addressed that? Did the researchers mention any potential sources of confounding that could have influenced the overall effect estimate of the meta-analysis? And did they discuss the implications of any sensitivity or subgroup analysis? So if different subgroups or different studies were disproportionately affecting the overall result, have they addressed this? Did they investigate the reasons for any heterogeneity across the primary studies? And did they discuss the effect of any publication bias? So if they did have significant results in the meta-analysis, but they had, their funnel plot or Eggers test showed high levels of publication bias, have they included this in the limitations and addressed that? And then again, you look at the limitations of the subgroup analysis if they were done. For example, if they gave a rationale for choosing the subgroups that they did, and if they didn't give a rationale, did they address how they came up with these subgroups? And if, that was done afterwards, if that could have introduced bias. And the same thing for the meta regression, if that was conducted. And then at the end of this section, you also look at, did they talk about if the benefits of the intervention outweigh any potential disadvantages? So, any kind of change that you're introducing, it will likely come with more resource demands, more financial demands, increased training and increased protocol need for the new intervention. So are they clear about the likely benefits of the intervention, bearing in mind its potential impacts or limitations? Did they discuss any potential disadvantages or harms associated with the new intervention? Did they talk about any demands for resources like cost, workforce, time, skills, training needs, data collection analysis needs, etc.? So, are they only painting a rosy picture of how amazing their new intervention is? Or have they also talked about, the potential side effects, the potential harms that could come, the potential, demands on resources, to give an overall balanced view of this new intervention that they're proposing? And then the last part here is, are the results of the systematic review relevant locally? Again, this is very subjective. It depends on who your study population is. If you're looking at a brand new medication that's amazing in adults and has a huge impact on, their overall health, but you work with kids and you work in pediatrics, for example, that piece of research is not relevant to your population, no matter how amazing the overall outcome is. There needs to be another study done specifically in the population that you're working with. Now, if a piece of research was done in a busy city center clinic, does that still apply to your clinic in the countryside, for example? Or like in a more kind of rural setting. So you have to be very strict when you're looking at any significant results and see what their population was and if that was exactly relevant to your population. And lastly, will the implementation of the results represent greater value for your service user or your population? So if you were to, implement these new interventions, does that actually have a meaningful impact on your population and their health overall? Or do the benefits are the benefits not outweighed by the harm? The harm outweighs the benefits. For example, you just don't have the resources in a smaller hospital to implement this new intervention that the big hospitals can. And if you were to put money aside, you're going to take money aside from other resources in your hospital and apply that to implementing this new intervention. Does that take away from important resources for your own community? And will that provide more harm than good? And that's it for the systematic review and meta-analysis of RCTs. Um, I'll just cover. There's just a couple of differences when you're looking at observational studies instead of RCTs. In your research question, they'll have a. It's a the PCOT criteria is kind of different. Instead of an intervention, you're looking at exposure or risk factor. And when you're looking at the methodology to see if the methodology is sound, for cohort studies, case controlled studies, you use the Newcastle Ottawa scale instead of the Cochrane risk of bias tool. That's it. So I know I went through a lot there. I was trying to go through it quickly because I was wary of the time. Any questions about what I've covered?
So I have few questions though.
Mhm.
So if the study includes unpublished, um, if it includes data from the unpublished article,
Yep.
and the study is not including that unpublished data, so which one is the better?
So, sorry, I'm just trying to understand your question. So you're saying that if they are including unpublished,
Yeah, if you include data from the unpublished article, would it be a better study?
it is better, and it took me some time to kind of understand why that was the case, because your initial thought is if you're including unpublished studies, you don't know if those are good quality studies or not. But when you're doing a meta-analysis, you are undertaking kind of, for example, like, you would assume that published research has been reviewed and peer reviewed properly. So it's a better quality research than something that's unpublished. However, when you're including studies in your meta-analysis, you're basically being a reviewer for each study yourself. So even if you're using unpublished studies, you're doing a quality review of each paper you're including. So whether that's a risk of bias assessment, whether that's, looking at the quality of the research and stuff. And you can, when you include the unpublished in your screening, when you do a full text screening, it's up to you to decide whether you're including that study or you're not including that study. So you might look at unpublished piece that was identified, as being as meeting your inclusion exclusion criteria, but actually, is a half complete study. The outcomes haven't been reported, and you think, okay, now I understand why the study wasn't published. It's not because it had good, it had non-significant results. It's because their methodology is all over the place. In that full text screening, you can decide to exclude that study and include a note in your kind of results to say this study was excluded. Because some studies will be excluded because it didn't meet the inclusion exclusion criteria when you looked at the full text, but some studies might be excluded because they're, incomplete or have incomplete results, for example. So you can exclude that, but what you're trying to do here is when you're trying to identify in your systematic review any possible research that could be relevant to your question before you do the screening, you want to identify everything that's out there, whether it's published or unpublished. Because, like I said, some unpublished pieces, like PhD theses, or dissertations, they're not published research, but they have an immense amount of information there. So you want to just be able to identify them, and then you can do your screening afterwards and you can remove them if they're not good, but at least you have identified them.
Yeah, got it. Thank you so much.
Any other
So,
questions?
yeah, one more question.
Mhm.
Can we use this checklist for the case reports as well, or that's only for the meta-analysis or observational studies?
So this specific checklist is for meta-analysis, systematic review and meta-analysis of randomized control trials. And actually, I said I was going to give you guys more information on it. These checklists I've got from, There's a link here somewhere. So just at the bottom here, the Critical Appraisal Skills Program. It's called CASP. It's a program, it's a UK course essentially. Their checklists are all free and available, and I will share them I'll share them again on the MedLit Dissect group. I actually did this course. And I did the full thing, and it was very informative. I learned a lot, but essentially, it just the course goes into more depth on these checklists and what you're looking for and some of the theory behind it. So if you guys want to do the course, I would recommend it for sure. But they have lots and lots of different checklists available for different pieces of research. I don't know if they've got one for case reports as such, because case reports are more, kind of subjective about uh, this is what we saw, this is what we did, this is what the outcome was, and discuss whether, that's kind of similar or different to what's available out there. People don't tend to use case reports to change their overall practice. They can use case reports to kind of get a better understanding of different treatment methods that are out there, or, try to keep an eye out for unique presentations of different illnesses, but they don't use it to like make guidelines and stuff. Whereas systematic review and meta-analyses usually do influence like, overall kind of approach to guidelines. So I don't think there is one for case reports. I'll have a look, and if there is, I will share it with you. But there's lots of different checklists for observational studies, for case control, cohort studies, RCTs, and many more. So I'll share that in the group.
Oh, sure. Thank you so much. Thank you so much for arranging this really informative session for me.
No,
Thank you.
you're very
Yeah,
welcome. I hope that was helpful. And
yeah, that was.
just wait, where are we? Just some final thoughts. You've got your four key questions when you're looking at any study, whether, the study design is valid, is the study methodologically sound, what are the results, are they trustworthy, and are they relevant to you? And just remember that not all evidence is equal. Just because it has the title of meta-analysis and systematic review and meta-analysis, it's not going to be, bulletproof. So be skeptical of what you read. Have a structured approach to critically appraising the evidence you encounter. And hopefully then that what you're doing for your patients, you've taken the steps to ensure that you're doing the best that you can for them. Okay, that's the end of my talk. If there's any questions, if you think of anything later on, you guys have my number. Just send me a message. If there's anyone new in this session who isn't part of our group, please, if you would like to be included, please just send me text me your name, and I will add you to the group. We tend to meet every 2 to 3 weeks, and we look at different papers. Some of our previous group members have shared their own pieces of research that they would like some feedback on, so they could, improve or learn for next time. And that was actually quite a helpful session. So, please feel free to join our group if you would like. And if there's nothing else, then I'll end the meeting right here. Thank you all for joining.
Thank you. Have a good day.
Thank you very much.
And you take care.